Good evening, everybody. Uh, at the onset, I'd like to thank all of you for joining this webinar and this teaching session. I know you've taken time off your schedules. Thank you very much. Mayank, am I audible?
Absolutely, sir.
And can you see my presentation also?
Yes.
Okay, perfect. So what we're going to discuss today is low back pain and a little bit about leg pain in the form of lumbar disc herniations and spinal canal stenosis. So low back pain is the back and neck pain are amongst the second most common reason why people go to see a general practitioner or seek medical advice worldwide. So the first or the most common reason why people go to see a doctor worldwide is upper respiratory tract symptoms, cough, cold, and the second most common reason is spine related problems. So it's either neck pain or back pain. So neck and back pains are something that general practitioners and orthopedic surgeons see all the time. And as spine surgeons, that's all that we see. So I'm going to divide this into three clinical scenarios. One is acute low back pain. The second is chronic low back pain. And the third is back pain radiating down into the leg. So the first one is acute low back pain. Very common scenario. Patients come with pain in the low back, maybe radiating down to the buttock, lasting for a few days. Does not typically radiate below the knee. Movements of the lumbar spine are painful in examination, and typically neurological examination is normal. Now, in the history, when you're speaking to the patient, it's always important to ask them to point out to where the pain is. Because when you ask them, do you have back pain? They'll say yes. And for them, the back may be, interscapular, thoracolumbar junction, or lower back. So it's very important that, what we think of as back pain is the same thing that they're trying to communicate to us. So ask them always to point out to the area where the pain is. And if they say they have leg pain, it's important to ask them to point out to the area where the leg pain is, because it may be just buttock pain, which they call leg pain. It may be posterior thigh pain, which they call leg pain, And these are not typically radicular pains. So radicular pains typically follow the dermatome of the involved nerve. So most of our lower lumbar disc pathologies cause pain going down below the knees. So this is acute low back pain, and fortunately it has got a very favorable natural history. The symptoms subside spontaneously in a majority of patients. And in these patients, X-rays and scans are not usually needed. And the pain normally settles down very well with a course of non-steroidal anti-inflammatories and maybe some physiotherapy. Exactly what physiotherapy we prescribe, we will get to later. But just remember, acute low back pain is a self-limiting condition, usually don't require X-rays and scans, and management typically consists of non-steroidal anti-inflammatories and physiotherapy. So that is low back pain. Very common thing. People come into your OPDs all bent over, not able to stand straight, and anything relating to the spine makes people very anxious. So it's important to tell them straight away that it's a good chance it'll all settle down and you'll be fine. And that itself makes them feel better. So the second one is chronic back pain. Now, chronic back pain is back pain that typically lasts more than 3 months and does not radiate down into the legs. In this clinical scenario, this is axial back pain. So it does not radiate down to the legs below the knees. It's aggravated by activities typically and certain postures, and the neurology is normal on examination. So the causes could be many. So it could be something as simple as muscle fatigue or poor posture. It could be arthritis of the facet joints or even disc degeneration. It could be spondylolisthesis or spondylolysis. Stress and anxiety also play a big part in chronic back pain and neck pain. And a lot of our patients who come to us with neck and back pain, if their X-rays and MRIs really don't show much, we get them evaluated by a clinical psychologist also. So patients with chronic back pain, I think it is worthwhile getting some scans and x-rays done to see what the cause of the pain is, instead of treating them blindly with NSAIDs or painkillers of any other sort. So you need to divide them into 2 or 3 different types of pain. Number one is the mechanical pain. So mechanical pain is typically dull aching. It increases with activity, is relieved by rest, and it does not usually radiate below the knee in the back, or if it's the neck, it's the elbow. So that is mechanical pain, as opposed to inflammatory back pain. So inflammatory back pain is typically more at rest. So these people complain of pain early mornings, and when they get out of bed, they have a lot of pain in the back, and it's typically relieved by activity, walking around a little, and then they start feeling better. It's exactly the opposite of mechanical back pain. The pain may be situated in the lower back, buttock, or the back of the thigh. And one thing to remember, if somebody comes with inflammatory back pain, is the possibility of seronegative spondyloarthropathy in the form of ankylosing spondylitis. And if it is very early stages, an MRI of the sacroiliac joints may pick up edema in the sacroiliac joint, signifying seronegative spondyloarthropathy. So that's something that you need to remember. So there's mechanical pain and there's inflammatory pain, and then there are the red flags. So the red flags, so low back pain is such a common complaint, but there are some that you cannot afford to miss. So anybody who comes with back pain below the age of 20 or above the age of 70 needs to be looked at a little more carefully. Anybody who comes with back pain following a significant fall or an injury needs to be looked at carefully. If the back pain is associated with fever or loss of weight or loss of appetite, you need to look at them a little more carefully to make sure that you're not missing out on any other pathologies. Worsening leg pain, numbness, weakness, and bladder problems are also red flags. Continuous pain at rest or night pain that disturbs people, disturbs the person, wakes them up from their sleep, is something that cannot be missed. And symptoms not settling with medications. This needs to be looked at a little more carefully. These are red flags. They may not mean anything, but you really don't want to miss out on any infections or tumors and things like that, which will benefit from early treatment. So these are the steps in treatment of chronic back pain. So in the early stages, there is definitely a role for physiotherapy if there is no deficits or things like that. So non-surgical treatment consists of predominantly pain medications, physiotherapy, and pain counseling. So if you think that there is an element of anxiety or stress, pain counseling definitely helps. Physiotherapy, exactly what type of physiotherapy we prescribe, we will get to later. And pain medications. If you're planning to give non-steroidal anti-inflammatories, a short course would be beneficial. If you're planning to give it for longer times, then you have other medications which are safer for long-term use. Spinal injections are useful in some instances, especially if you're looking at, if you think the pain is coming from the facet joints, spinal injections are useful, facet injections are useful. And if you have a surgically treatable problem like spondylolisthesis or spondylolysis, and if your patient has failed a trial of non-operative treatment, then surgery may be appropriate. The third case scenario, so we've discussed acute low back pain. We've discussed chronic low back pain, and the third one is back pain radiating down the leg. Now, typically, if you're thinking of a disc herniation, the pain should radiate in the dermatome of the involved nerve. So back of buttock pain and back of thigh pain are not radiculopathies. They're not radicular pains. Typically, these pains are aggravated by standing and walking. They may be associated with numbness and weakness in the leg. Disc herniation is probably the clinical diagnosis in this case. Lumbar canal stenosis is another diagnosis. So if you have a disc herniation like this, you can have radicular leg pain, you can have motor and sensory deficits as a result of the neural compression and the inflammation, or you can have a cauda equina syndrome. So So we look at the natural history of leg pain itself. So this is Weber's paper from way back. So we know from the literature available to us now that the leg pain is a self-limiting condition. So in a majority of people, the sciatica pain settles down spontaneously. So if you go back to what Hippocrates said, so Hippocrates, although he did not know that the leg pain was due to a lumbar disc herniation, he thought it was because of a subluxed hip. He stated that a majority of patients have complete relief of pain in 40 days. So that's probably that 6-week mark that we talk about. And he advised, a wide variety of treatment options, including warm water application, fumigation, laxatives, and even donkey's milk. So lumbar disc, the sciatica pain or the lumbar radiculopathy coming from a lumbar disc herniation is a self-resolving condition in a majority of patients. Around 70 to 80% of patients settle down without any form of surgical intervention. So before we go into lumbar disc herniation, I think I'll just briefly go through some of these terminologies which we see on the MRI scans. So when they say on the MRI that the disc is normal, so if you're looking at the axial section of a scan, that means that there is no extension of the disc beyond the interspace. Okay. And if you look at the posterior aspect of the disc, it's concave like this. So that's a normal disc. It's not extruded. Whereas a disc bulge is, so that concavity that you see there in a normal disc is lost and it's more convex like this. It's circumferential and not just a focal. So it's circumferential, symmetrical extension beyond the interspace is called a disc bulge. Okay. So you have disc protrusion, so disc extrusion, and disc sequestration. All of them come under the term disc herniation. So a herniation could be a protrusion, it could be an extrusion, or it could be a sequestration. So protrusions are typically focal, not circumferential. The nucleus material remains within the outer fibers of the annulus fibrosus. Okay, so it is also called a contained disc herniation. An extrusion, on the other hand, is when the nucleus has penetrated through the annulus fibrosus and is contained and is gone right through and through the annulus and is contained just behind the posterior longitudinal ligament. And the sequestration, we know, is when the extruded disc is not in continuity with the rest of the disc or not in continuity with the parent disc. Okay. So the indications for lumbar discectomy are clear. So we know that a majority of them settle down. So the treatment, the indications for surgery are when there is a failure of symptoms to subside following a reasonable period of non-operative treatment, when there is a significant or a progressive motor deficit. So just a EHL weakness is not an indication for surgery. And if you have a cauda equina syndrome, that's an indication for early surgery or immediate surgery. And these are one of the few urgent indications for surgery in the spine. Oops. I think that's hello. Sorry, Mayank, can you hear me?
Yes, sir, I can hear you, but can't see your presentation.
Yeah, I know something's not right. Yeah. Just give me a minute, sorry.
Sure.
Sorry, just having. Can you see my presentation now?
Not yet, sir.
Not able to share it. It's not.
So can you mail it to Mayank? Probably Mayank can show the presentation.
Okay. In the meantime, I'm happy to take some questions while we are doing this. Okay. I think I've got it done. I've got it sorted. Sorry. Sorry, I think I've got it sorted. Yep. Can you see it now?
Yes, I can see, sir.
Okay. So coming from lumbar canal stenosis, from lumbar disc herniation, we come to lumbar canal stenosis. This is a different pathology altogether. So we know that the pain in lumbar disc herniation, the leg pain is predominantly due to an inflammatory reaction that occurs near the nerves. We know that the lumbar discs, or disc for that matter, are avascular structures, and the minute the disc comes out of its place, the body doesn't recognize those proteins. And since the body doesn't recognize those proteins, it thinks of it as a foreign body. So there's an intense inflammatory reaction that occurs close to the nerve root, and that was what causes most of the leg pain. Lumbar canal stenosis is a different problem altogether. So lumbar canal stenosis is due to narrowing of the spinal canal. It could be due to vertebral spurs or disc bulging from the front. It could be due to fascial spurs from the side. It could be due to thickened ligamentum flavum or lamina enlargement from the back. And all this combines to reduce the space available for the neural structures, and this is what it looks like. On the sagittal and axial MRI sections, you can see that this whitish portion here is all the space that's available for the neural structures. So it typically causes pain that radiates down the leg, and the pain is aggravated by standing and walking, and is relieved by bending or any action that flexes the spine, increases the space available for the spine, for the neural contents, and thereby reduces the pain. So activities that provide relief are bending forward and holding a shopping cart, or even cycling with the spine bent forward causes relief of symptoms, whereas when they stand and walk, they have pain, typically in the calves, is referred to as claudication pain, and prevents them from walking for long durations of time. So may or may not be associated with a neurological deficit. So the natural history of lumbar canal stenosis is a little different from lumbar disc herniation. We know that lumbar disc herniation, like I mentioned earlier, has got a favorable natural history. A majority of them settle down. But lumbar canal stenosis, the natural history is not very favorable. So that means that if you do not do anything, it has been shown that a majority of patients continue to remain status quo. So surgery has been shown to provide greater improvement in symptoms. but a majority of non-operative symptom patients did not worsen. So this is from the SPORT trial that came out. So how does that affect decision making is that if the patient has got severe symptoms, then it's worthwhile offering them surgery, or if they've got deteriorating symptoms, it's worthwhile offering them surgery. Whereas patients with mild to moderate symptoms, non-operative treatment can be offered. So it is important to remember that a majority of patients continue to remain the same. A few of them worsen, but very few of them actually get better. So that is the natural history of lumbar canal stenosis, and surgery would be some form of decompression surgery. So we come to non-operative measures. So a majority of our patients require non-operative treatment, isn't it? So a lot of the back pains and the neck pains require non-operative treatment, and we speak very little about this non-operative treatment. Most of our conferences deal with surgical techniques and surgical indications. There are very few talks on non-operative measures. So we just look at 7 or 8 non-operative options that we have. So bed rest is not a great option for any kind of spinal condition. So if they have severe back pain or sciatica, enforced bed rest is rarely required. So you should not tell them. There is no advantage in telling patients that they need to take complete bed rest for a week or 10 days or 3 weeks or however. So there is no great difference. So this Cochrane review has shown that there is no big difference in asking patients to stay active versus bed rest. So what we tell most of our patients is we allow them to do whatever is possible for them within the limits of their pain. So we don't enforce bed rest, and strict bed rest more than 48 hours has been shown to be detrimental. The second one is traction. This was a hot favorite in the past, but popularized by Hippocrates himself. There is rarely any indications for traction for spinal conditions. So the only time we use a bit of traction, which I use a bit of traction, are severe scoliotic deformities when we apply some traction, in-hospital traction, continuous traction for a couple of weeks before surgery. But as a pain relieving measure, I don't think there is any role for traction anymore. Now coming to physiotherapy itself. So back exercises, core stabilization exercises are a good option for neck and back pain and acute and chronic pain. Regarding electrotherapy, shortwave diathermy, ultrasound, TENS, there is hardly any evidence to say any of these work. Most of the people I work with, at least, I haven't used this for more than 10 to 15 years now. And even physios, when you speak to physios, they also are quite reluctant to use electrotherapy because there is no evidence that it actually helps. Medications, NSAID is definitely the first line of treatment. Don't think there is any evidence that one NSAID is better than the other. I do try oral steroids in patients with cervical disc herniation, just because the complications associated with cervical nerve root blocks are slightly more than that associated with lumbar nerve root blocks. For lumbar disc herniation, I use nerve root blocks, but for my cervical disc herniations, I give them a tapering course of oral steroids, so that is an option too. Anticonvulsants like gabapentin and pregabalin is something that we use a lot for neuropathic pain, and so is amitriptyline. Fluoroscopy guided steroid injections, excellent option for lumbar disc herniations, and gives nearly immediate relief. So we looked at our series of patients who had lumbar disc herniations. So we give them lumbar disc herniations very early in their, usually in the first or maximum the second visit, we give them a lumbar disc, nerve root block. And we looked at the temporal pattern of reduction in pain, and we found out that there is a 70 to 80% reduction in pain within half an hour of the injection. So I think it's an excellent option, and it's worthwhile doing it early. You save, you save the patient so much of suffering and pain and disability as a result of this. The complication rates are very, very low. So this is what the evidence currently shows us. So exercises, multidisciplinary rehabilitations, there is definitely evidence for that. Spinal manipulation and massage may be a transient effect. Traction and ultrasound and other forms of electrotherapy are clearly ineffective. Acupuncture and hydrotherapy, hydrotherapy, warm water pools are a good option in elderly people and people who suffer with back pain, but acupuncture we don't know. So the way I work with my physiotherapists is that I don't tell them what to do. So I send them for the physiotherapy and let my physiotherapists take a decision on what kind of physiotherapy modalities are going to be useful for that particular patient, and it's based on the assumption that they clearly know more physiotherapy than I do. I clearly don't know much physiotherapy, being a surgeon, and so I've chosen good physio. I work with a team of very good physiotherapists, and they decide what kind of treatment the patient requires. And most of the time, they are offered something called manual therapy and exercises that some of them get some dry needling also, but no electrotherapy. And our physiotherapy sessions occur once or maximum 2 times a week, and that goes on for 4 to 6 weeks. So that's how we treat our patients non-operatively. And that's the end of my talk. I've tried to keep it as brief as possible so that so that there's more time for questions, and I'm happy to take any questions.
Hello. Hello.
Yes, I can hear you.
Good evening, Thomas sir. This is Dr. Ramkishore from Andhra Pradesh.
Yes, sir.
Sir, I would like to know about your oral steroid course. What kind of medication you are going to give, and what is the duration of the steroid?
Okay, I don't think there's much evidence in literature on whether one is better than the other. So from when I speak to my colleagues, I find that everybody is giving different steroids for different durations of time. So I can tell you what I do. So I give prednisolone 10 milligrams 3 times a day for 3 days. And then after the first 3 days, we reduce the dose to 2 times a day for the next 3 days. And then once a day for the last 3 days. So 3 times a day for first 3 days, 2 times a day for the next 3 days, and once a day for the last 3 days. But make sure you give them some proton pump, some gastroprotective medications along with it, because steroids cause a lot of gastritis. Okay. And the other thing to be aware of is that, if your patient is diabetic, you need to be very careful because the blood sugars will shoot up.
What is your steroid in transforaminal route, sir?
That's a good question. So I use triamcinolone.
Okay.
But we need to be aware that the best option is a preservative-free steroid.
Okay.
And preservative-free steroids are not available in our country currently.
Yeah. So actually, coming to the steroid point, transforaminal, actually non-particulate steroid is the ideal. It seems like a literature says.
Non-particulate without preservatives.
Without preservatives.
So preservative-free betamethasone is probably the ideal one.
Yeah.
But it's not available.
Yeah. But we are giving only triamcinolone, Kinacort, or Dipometrol, sir.
Yes.
But some literature, somebody there is telling that with Dipometrol there are some issues, like so better to change from Dipometrol to Kinacort. Like, is it anything like that, sir?
No. So the problem occurs because it's see, the thing is the Depomedrol comes in a little box, and it's got a pamphlet in it which clearly mentioned that it is not for epidural use.
Okay.
And there's been somebody who has been sued in Delhi. There was a medical legal case because the patient developed some issues after a midline epidural, not a nerve root block actually, but after a midline epidural. And one of the problems was that they'd used depomedrol, and it clearly mentioned that is not for epidural use.
So for transferable, it's okay, sir? For transferable?
Ideally not. Ideally,
Okay.
you should use, like you said, non-particulate preservative-free steroids.
Like Kenacort something.
Kenacort is firstly, it's not. It has got a preservative, and the preservative in that goes with triamcinolone is benzyl alcohol.
Okay.
They're no neurotoxics.
So
Yeah, we do use it. We do use it, but you need to be aware that it's not the best thing to do.
So for ideal transferable,
ideal. I think most people use triamcinolone.
Okay. Thank you, sir.
Yeah.
Sir, can you hear me, sir? Dr. Sujit
Sure.
here.
Yes, sir.
Sir, about one of your slide in lumbar canal stenosis, it
Yes.
shows mild, moderate, severe gradation of symptoms. So, any criteria of differentiating?
Not exactly, but I think it's more clinical, and we go by what the patient's walking distance is.
Okay.
Or walking time. So we ask them, how many minutes can you walk? If somebody says, I can walk an hour and then I get bit of pain in the legs, well, we think, you can hold on for some time. But if somebody says, I can't walk for even 10 minutes, I have to sit down, well, that is what I would consider a severe claudication.
Okay. Sir, any change in if radiculopathy coexists with the claudication, any change in your management of lumbar canal stenosis?
Radiculopathy, sometimes it does happen, wherein you have the radicular pain, which is more constant pain, and the claudication pain is usually on and off, so it is there only on standing and walking, relief by sitting. But you're splitting hairs with that.
Okay, sir. Okay, sir. Thank you, sir.
Yeah.
Hello.
Yes, sir.
Can you hear me?
Yes, sir.
Yeah, I'm Dr. Nalli Yuvraj from Chennai.
Yes, sir.
Yeah. Regarding the steroid use, I think triamcinolone acetate is the one which is ideal. And as you said, the depomedrol should not be used because it's clearly given in the literature that it should not be for use for intrathecal.
But even triamcinolone, if you look at the literature on triamcinolone on the net, it clearly mentioned that it is not for epidural use.
So what steroid would you like to use then?
Sir, I use triamcinolone, but you need to be aware that it does come with a preservative, and the preservative is neurotoxic.
Anyway,
and the preservative in triamcinolone is benzyl alcohol.
So triamcinolone acetate is the one which is commonly used.
It is the most commonly used, but it does come with a neurotoxic preservative.
Yeah. Then regarding your comment on the advice of the physiotherapist.
Yes.
I think probably you are having a good set of good physiotherapists.
Yes.
I think for the youngsters who are going to listen to this talk,
yes,
I think it's better to advise. I think we should give the advice rather than leaving it to the physiotherapists, because not all physiotherapists are good. You should remember that.
Well,
we are going to, because a lot of times people have directly gone to the physiotherapist and they come back to us with a lot of aggravation of pain. So such situations, like they say they would have done some manipulation, that there's the various treat modalities have been tried by the physiotherapist and they come back to us. I think it's good advice to tell our youngsters that we should know something about physiotherapy, and then we should advise the therapist on the method of treatment, the mode of management. And that would be a better advice than leaving everything to the physiotherapist.
So physiotherapy
this is my view. This is my view. Yeah.
Okay, fair enough. Irrespective of you, sir.
Yeah.
Physiotherapy has become a very big, specialty by itself, and it's as surgeons, it's not really possible for us, because the physiotherapy, the way they think and approach spinal problems is very different. So as surgeons, we normally approach spinal problems from the anatomical and pathological point of view. physiotherapists are very different. They look at everything in terms of function. How do we improve function and things like that. So I think it's very important to have, if you're in practice, especially if you're in orthopedic or spine practice, to have a group of physiotherapists who see most of your patients instead of sending them to different physiotherapists every time. I think if you have a more regular set of physiotherapists, then you know exactly what their abilities are, and they know exactly what you want from them. So I think that's a good option instead of but at the end of the day, you need to know that electrotherapies don't work, and it's mainly manual therapy, exercises, and things like that will work in the long run. Because we still see a lot of people sending patients off
No. Yeah.
electrotherapy treatments, which clearly don't work.
Yes, Kishen, regarding the electrotherapy also, in my 27 years experience in treating back pain and spinal ailments, I have been regularly advising them bed rest, putting them on traction. Sometimes people who are not being put on traction, once you add the traction, they get a lot of relief. And the basic thing is I put them on at least a 3 weeks trial of electrotherapy. Only then I advise them surgery. Like I start them on a therapy, like electrotherapy, and supposing they get a relief, then I continue for a second week till they get a good relief. So in fact, I tell them that I'll give a good trial of 3 weeks electrotherapy. Only then I will take you up for surgery. So I think in my experience, I've seen that the physiotherapy has a very good role in the management of low back pain, especially the traction and the electrotherapy.
Okay, sir. Thank you.
Yes.
Hello, sir.
Yes, sir.
Sir, what is your maximum allowable point for beyond which the conservative is not beneficial, like that you are going to think like?
It depends on what condition it is.
For example, like LDH.
I'm sorry, lumbar disc herniation?
Yeah. Yes, sir.
So see, it all your indications for surgery and decision for surgery is dependent on the known natural history of the condition.
Yeah.
So we know that with lumbar disc herniations, a majority of them settle down within 6 to 8 weeks.
6 to 8 weeks. Okay.
Yes. So I after 6 to 8 weeks, we start talking about surgery.
Okay. Only after 6 weeks.
At least because a majority of them will get better within 6 weeks. We know that around 80% of them get better within 6 weeks.
Okay. And one more question is there any clinical objective signs are there to tell that this is because of the LDH and this is because of the facet pain, facet joint pain, and this is because of the SI joint pain? Is there any clinical objective, 1 or 2 signs are there, sir, to differentiate?
I think a lot of it comes from the history. So typically patients with lumbar disc herniations have got pain that go all the way down into the leg, beyond the knee. Okay?
Yeah.
The pain is acute onset and constant, aggravated by any movement.
Okay.
Facetogenic pain from the facet joints.
Okay.
Typically felt in the lower back, gluteal region, and back of the thighs. They are typically more on any movement that causes extension of the spine.
Okay.
So when they go from sitting position to standing position, they may develop pain in the back.
Okay.
That is more in favor of a facetogenic origin of pain.
Okay.
What was the third thing you told me, sir? Sacroiliac joint, is it?
Yeah. Because the LDH and SI joint, sacroiliac spine, both are looking to same, like from the back to the leg. Both are from the pain arising with the low back.
Sacroiliac joint pain does not go below the knee. Very rarely, if at all.
Okay.
But for most practical purposes, it does not go below the knee.
Okay, sir. Okay.
So pain from lumbar disc herniation will follow a specific dermatome.
Okay.
So if it's an L5 radiculopathy, the pain will be on the outer side of the leg.
Okay.
If it's an S1 radiculopathy, the pain is in the back of the calf.
Okay.
So it follows a specific dermatome.
Okay.
Facetogenic pains and sacroiliac pains don't usually follow a specific dermatome.
Okay.
And they very rarely extend below the knee.
Okay.
So it's very important to ask patients to actually show you where the pain is with their finger. Point out to the area. If you ask them there is leg pain, they may say there is, but it may be gluteal pain or posterior thigh pain, and that is
Okay.
not radicular pain.
Okay, sir. Okay. Thank you, sir.
Thank you, sir.
Hello. Hello, sir.
Hello. Yes.
Sir, this is Manoj, sir.
Yeah. Can you just go back a little from your mic? I think you're too close to your mic.
Sir, is there a role of epidural steroid in lumbar canal stenosis, sir?
Good question. There are people who do it, but I don't normally do epidurals. I don't do epidural steroids for any condition at all. Sorry. So the only thing that I do is nerve root blocks, and yeah, you can use a nerve root block in lumbar canal stenosis, but usually the results are temporary or results are transient.
Okay, sir.
You need to know what is the natural history of lumbar canal stenosis first.
Yes, sir.
So we know what the natural history is. They don't respond very well to most non-operative treatments. So you just go by the symptoms. If the symptoms are mild, you can treat them non-operatively. If the symptoms are severe, they don't usually settle down with non-operative treatment.
Okay. Thank you, sir.
Sir, can I ask one more question, sir?
Of course, sir.
Yeah. Sir, is the MRI indicated in first visit of vascular pain without neurological deficit?
Yeah, that is a good question. So it depends on what your practice is. So yeah, if there is, yeah, you can look at it both ways. You can treat them with NSAIDs and some pregabalin and wait it out and see, because we know that the majority of them settle down. Okay.
Okay, sir.
But I
Sir,
normally get an MRI done early in the course, because a lot of my patients get the nerve root blocks very early. And the reason why I give nerve root blocks very early is that we have seen from our studies that there is 70 to 80% relief of pain within half an hour. And I think it's worthwhile giving them that immediate relief. So if you're planning to give a nerve root block early, I think you need to get an MRI scan done first. So the reason why I get an MRI scan done early is because I give them a nerve root block early in the course of the disease. But if you're not planning to, I mean, you don't have to. You can treat them with NSAIDs. You can treat them with other medications and wait it out. That is also an option.
Okay, sir.
Yeah. Any more questions? Mayank?
Yes, sir.
Any more questions? Somebody's...
I don't see it in the chat window. I think the participants can actually unmute and ask questions.
Yeah, you can ask. Yeah.
Hello, sir.
Yes, sir.
So this is Ram Kishore, sir.
Ram Kishore, sir, tell me, what can I do?
Yeah. Sir, actually, while asking the instability X-rays, flexion and extension is better, or flexion and supine lying lateral is better?
Oh, flexion extension versus?
Flexion extension versus flexion and supine lying lateral. Because I feel that supine lying lateral, there is relaxation of the muscles are there. So when there is any instability in flexion, it is more. There is some sort of way to go backward.
Okay.
Compared to the extension where there is some kind of muscle tight is there. So is there any that's what I think. But what is your opinion, sir?
I don't think there is, Ram Kishore, but there are people who believe that just taking a standing lateral also can exhibit some form of instability. But then, when you talk about instability, you're not looking at some microscopic kind of instability, isn't it?
Yeah. Yes, sir.
So if you're, see, what are you looking for? You're looking for something that may require, so if you're doing a decompression, you want to know if there's instability that may require you to do a stabilization procedure.
Yeah.
So for that, you need to have significant amount of instability or anteroposterior translation of the vertebra. You're not looking at some microscopic amount of translation to make your decisions.
Okay.
So, I think we are splitting hairs when we talk about, flexion extension versus standing lateral versus lying down lateral. If there is instability, there is instability. We're not, if there's it requires you to look at it under a microscope, then there's probably no instability, is what I think.
Yeah. So standing flexion extension is better, or like lying down?
I don't think there is much difference actually.
Okay.
We do lying down flexion extension.
Lying down. Okay.
Yeah.
Thank you, sir.
Yeah.
Are there any last questions from the participants? Sir, I don't see any questions in the conversation, so I'm encouraging participants to kind of unmute and ask questions.
Yeah. The other things to remember in disc herniation is that, the size of the disc, the position of the disc really does not have much to do with your surgical decisions at all.
Okay.
So if you may have a very large looking disc, you may have a sequestrated disc, you may have, inferiorly migrated disc, but those are not surgical. Those don't really affect your surgical decision making of whether the patient should have surgery or not. It may change your surgical technique a bit, but rarely changes your surgical indication. Because it has been shown that larger discs, extruded discs and sequestrated discs sometimes resorb much quicker than contained discs.
Okay.
So I think important to remember that acute low back pain is a self-limiting condition, rarely requires X-rays and MRIs. Most of them settle down with some NSAIDs and some form of physiotherapy. Chronic back pain requires a little more investigation to see what the cause of the back pain is. And if you're planning, whatever treatment you're planning, it is useful to use a step ladder kind of an approach where you start off with simple treatments before you go into surgical intervention, unless, of course, the patient has some neurological deficits or bladder dysfunction. And very important to know that the natural history of lumbar disc herniation is very favorable. 70 to 80% of patients don't require surgery and they settle down with non-operative treatment. A small portion do require surgery, and in which case it's you can choose between a micro discectomy or something more minimally invasive. Lumbar canal stenosis, on the other hand, the natural history is not very favorable. They don't respond very well to non-operative treatment like lumbar disc herniation. So you go by the symptoms. If they are significantly symptomatic and the symptoms of claudication prevents them from standing and walking and that really affecting their normal day-to-day activities, then you can advise surgery early on in the course of the disease. Or whereas on the other hand, if they have pain that allows them to, or pain that does not really disturb their normal day-to-day activities or the activities of daily living, then you can give them a trial of non-operative treatment. And we've spoken about what the non-operative treatment options are. So there is not much role for traction and electrotherapy in most spinal conditions. There's lots of evidence on that. There's a lot of So what currently physiotherapists do is a combination of manual therapy and exercises. There is no, and most of the time, patients don't require daily physiotherapy. Once or twice a week physiotherapy that goes on for 4 to 6 weeks is usually adequate. And some of our physiotherapists have started, have been using dry needling for quite some time, and some of our patients do pretty well with dry needling. So, any more questions? I'm happy to answer questions.
Sir,
Yes,
one more question, sir.
Of course.
This is Ram Kishen.
Yes, sir.
Hello, sir.
Yes, I can hear you.
Yeah,
Sir,
sir.
maybe
In a
crying at the
scenario
back or what?
yeah, my daughter. Yeah.
She's not happy with you talking. She's
One
not happy
second.
with you talking on the computer.
No, 1 second, sir.
Hey, don't worry. Tell me.
Yeah, so in scenario like back pain due to ankylosing.
Ankylosing, yeah.
Yeah. In that scenario, what is your choice of NSAID and what is your choice of DMARD?
Oh, okay. So, back pain from ankylosing spondylitis.
In the early course.
I work in a multi-speciality hospital, so I have the benefit of sending them off to the rheumatologists.
Okay. If you don't have that kind of setup, like
I think I don't know whether any one NSAID is better than the other, but a lot of them prefer indomethacin, NSAID wise. SAS is something that most rheumatologists use.
Okay.
But if you can put them on TNF alpha blockers, I think that's the best.
Okay.
It really changes the it makes a big difference to the stiffness as well as the pain in the early stages.
Okay.
But the downside is that it is an expensive drug.
Okay.
And you need to follow them up quite carefully, because firstly you need to make sure that they don't have tuberculosis before you start the drug.
Okay.
So,
sir,
yes.
In that scenario, do we need to prefer any kind of SA joint injection for better, control of the inflammation? Is it anything like that, sir?
Does not give, it gives transient relief only.
Okay.
So you will get better relief if you're going to use TNF alpha blockers, I think. But I normally let my rheumatologists take those decisions.
Okay. Thank you, sir.
Thank you. Is that all, Mayank? I think.
Yes, sir. I think thank you so much, sir, for enlightening session. And I am sure all the participants and respected delegates have really enjoyed the presentation and it was really insightful. I really appreciate you taking out time, sir, and thank you so much for that. And we continue to do that, sir. Thank you for your cooperation. Time.
Thank you, everybody, for coming. Thank you very much.
Thank you, Thomas, sir.
Thank you. Stay safe.
Thank you, Dr. Thomas.
Stay away from the coronavirus.
Right.
Bye.